cuffed in a bando. White boy in his sandals. Police like a Rambo. Blow it out like a kendo. Sambo. Me and you was friends, but to them we the opposite. The same mistake, I'm in jail, you on top of shit. You living life while I'm walking around mopping shit. Tech kid, backpack, no you a college kid. All I wanted was to break the rules like you. All I wanted was for them to love me too. But no matter where it was, I always stood out. Black Waldo, dancing with the thick brows. We was both running naked at the luau. We was both on shrooms, praying face down, waist down. Remember when they told you I was too black for you? And now my black popping like a bra strap on you. I was kicked out, said I'm too loud. Kicked out, said I'm too proud. But all I really ever felt was stressed out. Kinda like my afro when it's pressed out.
Hola, me llamo Carballoni Jr. y soy el vicepresidente y director de defensa de AIDS United. Bienvenido a AIDSWatch. Estamos muy contentos de que se haya unido a nosotros hoy. Hi, my name is Carballoni Jr. and I'm the Vice President and Chief Advocacy Officer here at AIDS United. Welcome to AIDSWatch. We are so glad to have you join us today. Escuche atentamente a la información sobre los servicios de traducción. Seleccione su idioma usando el botón de interpretación en forma de globo terráqueo. Si usted está usando su computadora, el botón de interpretación se encuentra ubicado en la parte inferior derecha de su pantalla. Si usted no desea escuchar la narración en inglés de fondo una vez que haya seleccionado su idioma, vaya a la opción Menú y seleccione Silenciar audio original. Si usted está usando un dispositivo móvil, Android o Apple, haga clic en los tres puntos ubicados en los controles de la reunión y seleccione Interpretación del idioma, luego seleccione Español. Si usted no desea escuchar la narración en inglés de fondo, seleccione Silenciar el audio. Gracias. Comenzaremos la presentación en breve. Thank you. We will begin the presentation shortly.
Thank you all so much for joining us for our last session of Day 2 of AIDSWatch, discussing congressional funding and programmatic support for the programs that support people living with HIV. I'm going to turn it over to our moderator for today, Dr. Eugene McCrae.
Thank you, and welcome everyone. Welcome to our panel today. I'm Dr. Eugene McCrae, former director for the Division of HIV/AIDS Prevention at CDC, and I'm currently serving as a member and vice chair of the Board of Trustees for AIDS United. The panel today will focus on Congress's role in funding and prioritizing the programs and organizations that serve people living with and vulnerable to HIV daily. Congress must accelerate and support ongoing efforts to end the epidemic in the US by 2030. You will hear from local experts about how the money and bureaucratic processes can truly impact the HIV epidemic in both negative and positive ways. The appropriations of funding we will focus on in this session includes the Ryan White HIV/AIDS program, housing opportunities for persons with HIV, or HOPWA, Minority AIDS Initiative, CDC Opioid HIV Syndemic Response, and the End the HIV Epidemic Initiative, or EHE supplemental funding throughout the federal government, including programs that accelerates PrEP access, such as the Ready, Set, PrEP program. So we have 4 really outstanding panelists today who will be discussing and sharing with you examples of how HIV funding decisions and bureaucratic processes at the federal level impact their programs and the work that they do every day to support their constituents and their community. I will briefly introduce each of the panelists in the order they will speak. After the intros, Each panelist will speak for 6 to 10 minutes and tell you a bit more about themselves at the beginning of their presentation. And then we'll move to question and answers after the last panel has spoken. So I'm really honored today to introduce the panel members. The first speaker will be Kathy Ayers. She's the Chief Executive Officer for AIDS Alabama in Birmingham. She will be followed by the next speaker, who is Carl Baker, who is Director of Legal and Legislative Affairs at Desert AIDS Project in Palm Springs, California. You will then hear from Omar Martinez Gonzalez, who has recently assumed a position as Senior Manager of Policy and Advocacy at AIDS Foundation of Chicago. And then you'll hear from Carl Belloni Jr., who's Vice President and Chief Advocacy Officer at AIDS United in Washington, D.C. And the final speaker will be Nana Khanna, who many of you, I'm sure, know. She's the Co-Executive Director at Positive Women's Network, United States of America in Oakland, California. So without further ado, I will pass this, the microphone on to our first speaker of today, and that's Kathy Ayers.
Thank you, Dr. McCray. And it's a pleasure to be here with all of you. Although I will admit, I really look forward to the day when I can see you in person. So I guess my slides are up, so I'll go ahead and start. So my name is Kathy Ayers. I'm the CEO at AIDS Alabama in the Deep South, where we have lots of issues, but certainly one of them is housing for people living with HIV. So if you'll go to the next slide, please. For many years, we went to Congress and they wanted proof that housing is effective for people living with HIV. Now, you'd think that would be a no-brainer because without a decent, safe, affordable place to live, it's very difficult to maintain any kind of medical regimen. But we decided to try to find that proof for them. So the National AIDS Housing Coalition started what we call the North American Research Summit. And every other year, we invited many of the country's top research specialists in HIV to come and help us to develop research around housing. And while that wasn't something that had been done before, they got really excited about it. And we had some really wonderful researchers. And in fact, over a course of about 6 or 8 years, they put together so much research proving how important housing is to people living with HIV that we filled an entire medical journal called AIDS and Behavior with that research information. Next slide, please. So this is our mantra at AIDS Alabama and at the National AIDS Housing Coalition. Housing is healthcare, because we know from the research that being stably housed is associated with good things like effective antiretroviral treatment. Do you know that you're 20% more likely to achieve viral suppression if you have a safe, decent, affordable place to live? And so that brings us to U equals U. Undetectable equals untransmittable, which I think has been one of the biggest stigma busting discoveries in my time in HIV, because we know that people with a suppressed viral load cannot sexually transmit to other folks. We also know that people with good housing seem to have much lower co-infection rates with Hep C and tuberculosis. And here's the big one: reduced mortality. Now, you don't get a much bigger outcome than that. The death rate due to HIV among homeless people living with HIV is 7 to 9 times the death rate of folks in the general population of HIV. So that's huge. And we need for folks to understand how critical the housing piece is. Next slide, please. This is one of my favorite researchers, Dr. David Holtgrave. He used to be at the CDC and then at Johns Hopkins. I believe he's up in Albany, New York now. but he is really the guru around figuring out how much things cost. And in his research, he had many conclusions, but one was that HIV prevention and care will not succeed without addressing the structural barriers, such as homelessness and housing instability. And, David was able to prove that housing for persons with HIV not only saves lives, but it saves taxpayer dollars. It's a sound healthcare investment. And when you compare it to other diseases and interventions, it is cost effective. And probably most important, he was able to determine that housing status is probably the most significant determinant of a person living with HIV's health and risk outcomes. So David agrees with me that you don't get anything much more important than housing when it comes to HIV. Next slide, please. And homelessness. I mean, we all know that homelessness in the United States is a huge issue. And it's also a major risk factor for HIV. The rates of HIV infection are 3 to 16 times higher among the homeless or unstably housed when compared to people in stable housing. And 3 to 14% of all homeless people are HIV positive. That's about 10 times the rate in the general population. And we also know that at least half of all people living with HIV experience homelessness or have housing instability at some point in their lifetimes. Next slide, please. So let's talk some numbers. I have numbers here from 2019. And we know that almost 1.2 million people are living with HIV in the United States, right? But about 400,000 of those people will need housing assistance during the course of their illness. That's 1/3 of that 1.2 million people. Currently, today, 140,000 households with HIV lack stable housing or they desperately need assistance. And yet the housing opportunities for persons with AIDS, which is the only HIV-specific housing program in our portfolio, only serves a little over 50,000 people living with HIV with housing assistance. So that means 62% of the people that need assistance today are unable to get it because of lack of adequate funding. Next slide, please. Here's what I think of the president's budget. And I know I'm being a little silly and flippant here, but I have to say, I am so disappointed in the 2022 and the 2023 budgets that the Biden administration has come out with. Next slide, please. So this is 2 years in a row that we've gotten inadequate HOPWA funding. The 2023 budget added a whole whopping $5 million to HOPWA. So it moved from $450 million to $455 million. I'm sorry, but that doesn't even cover inflation. And we will talk about it some more in a minute, but COVID has only worsened the situation in both being able to find housing and in the price of housing going up. And when we got the $450 million last year, do you know that jurisdictions lost $15 million because of the lack of adequate funding? We had asked for $600 million and we got $450. So some jurisdictions actually lost money. I know the Biden administration has declared that they will end the HIV epidemic, yet they have not addressed one of the cornerstones of health, and that's housing. So, a lot of times I hear them say, but there are lots of other funding streams for housing. There's Section 8 or the housing choice vouchers. But you know what? Most of those do not have any set-asides for people living with HIV. And if you're anything like we are in Birmingham, and you try to get on a housing choice voucher, you may have a 5-year wait. And I think for most people living with HIV, that's just a little bit too long. Next slide, please. So ending the HIV epidemic, we're all for it. But you know what? It's not going to happen without safe, stable, affordable housing. Next slide, please. So here's the bottom line. We need you, and your voices are very important. Let me emphasize that right now. As you talk to your congresspeople and senators, just know that they work for you and your voice is important. And we need $600 million, which is a good bit more than the president put in his budget. But we know that HIV housing improves medical outcomes, it prevents new cases, and it is cost effective as an intervention. So I want you guys to spread the word to your congresspeople that we care a great deal about housing for people living with HIV. And I believe that's the end. Next slide, please. All right, so thank you for talking to our elected officials. I look forward to seeing you, and I'll be hanging around to answer any questions at the end. So thanks a lot.
So Carl.
Hi there. You see me. My name's Carl Baker. I'm in Palm Springs, California at DAP Health, and I want to thank Kathy for her great presentation. So I'm going to piggyback a little on that and combine a little housing and HIV and aging. California and a lot of other states, as you know, we have a serious problem with the affordability of housing. So even out in the desert, which a lot of people try to escape the big cities for more affordable housing, even now the prices here in Palm Springs have become just too expensive for the average person to live. So we do need more assistance for HOPWA funding. We were lucky here at JP Health. We are just beginning construction of 60 units of affordable housing. We can no longer set that fully aside for HOPWA funding, but we can try and use our current wait list for our housing, which we have 70 units on campus right now. That is all HOPWA funding, but we have a 2-year wait list for those apartments. So we're going to try and use that wait list to seed into our new housing projects we're building. Coupled to that is our HIV and aging. Palm Springs is unique in that it has a large percentage of HIV positive individuals such as myself over 50 years old. So there's a lot of activities here for people who are aging with HIV, and we're trying to look at structural solutions. And again, housing is one of the biggest obstacles that people are facing, especially those who were on disability, who are running out of their regular paychecks. So now they're going to go into their retirement age, but they're going to be funded on the salaries they were making, for example, back in the 80s. So that's really going to hit them really, really hard. So we have a lot of people who came down from San Francisco and LA in the 80s to escape the epidemic of HIV, but now they're retiring age and they're finding housing is becoming unaffordable. So the two are sort of tied in together. You don't have one without the other. And even for younger individuals who are moving out here because of the lack of career path jobs, people that work in the hospitality industry are also struggling to just find a place to live. As Kathy said, we also believe that healthcare is housing. I mean, you can't take care of yourself if you don't have a safe place to live, a place to store your medicine, a place to just get a glass of water and sleep in a safe environment. So we really want to stress these programs. One thing we're looking into is called the PACE program, PACE. It's also another government program that's designed for the elderly. The idea is, to me, it's sort of like kindergarten. There's a morning session and an afternoon session. They bring in bus loads of people up to 40 or 50 to one place. You're served a meal. The dental services are there, medical services are there, and behavioral health services are there. So you come in, you see all of your appointments, you get to eat, you get to interact, and then at 12 o'clock, that group leaves. 1 o'clock, a new group comes in for another 4 hours. So we're looking at exciting ways to beat the stigma of having HIV and growing old and create housing and community and loneliness. I mean, that's one thing we really hear a lot is people are living in isolation. So we want to break that isolation, bring people together and show them what services we have for them. Luckily in California, we have Medi-Cal, which is a provider of Medicaid in this state that's open to anyone who's under 200% of the federal poverty level. So that means if you don't have a job, at least in California, you are able to receive all your medical benefits, lab tests, prescription drugs, and doctor's visits. But we're sort of an outlier. I mean, we understand that's not the rest of the country. So we're very fortunate to be where we are, but we want to work strongly with on a federal level to increase Ryan White. One goal that we really want to work towards is Ryan White has been so successful in preventing HIV spread that we're trying to figure out a way that we can get PrEP services paid for through Ryan White. Although those patients are not positive, so they don't qualify for Ryan White. But that's one thing we're looking at to try and see, well, this works so well. The program is already in place all over the country. And we just need to somehow figure a way we can open up the doors to negative individuals and put them on PrEP through the Ryan White program.
So, thank you, Carl. And I get, are you finished?
Yeah.
Good, good. So we'll move now to Omar.
Hello, everyone. Can you hear me? Excellent. So it's a pleasure to be here. Again, my name is Omar Martinez Gonzalez, and I am the new addition to the AIDS Foundation of Chicago, Senior Manager of Policy and Advocacy. I have spent the last couple of years, or not the last couple of years, I'm sorry, the last 5 years working in direct services in HIV and AIDS prevention, both here in Chicago and in Boston, Massachusetts. So I bring that perspective to this presentation. Next slide, please. To start off, I want to give you some background into the AIDS Foundation of Chicago. So our mission is to mobilize communities to create equity and justice for people living with HIV or who are vulnerable to HIV and chronic conditions. We were founded in 1985 by community activists and physicians. The AIDS Foundation of Chicago has 4 strategic priorities. One being to end the HIV epidemic, unite to end homelessness, prioritize racial equity, and team up for justice and change. Next slide. Our key programs include case management, so connecting people and helping them to navigate systems that connect them to HIV medication, housing, food, transportation, and other necessities. We have a prevention and community partnerships program where we partner with community organizations throughout Chicagoland, nationally and globally, to prevent prevention education, resources, support to priority populations, and capacity building and technical assistance. We have a housing program where we partner with community organizations across the Chicago metropolitan area to provide shelter for vulnerable people living with HIV and other chronic illnesses. And of course, we have the policy and advocacy team to amplify the voices of the HIV/AIDS community, not only here in Springfield and Illinois, but at community trainings and conferences, and locally, statewide, and nationally. Next slide, please. Well, let's get to the nitty-gritty of this discussion, which is what's included in the federal fiscal year 2023 budget. So it includes harm reduction. While the administration didn't provide potential opportunities for harm reduction funding elsewhere in the budget, it's not clear how much of that money will go to harm reduction programs. The budget only provided $1.5 million increase for CDC opioid-related infectious disease, and the Biden administration did not explicitly call for the repeal of the ban on federal funding for syringes at syringe service programs. I think what's important to understand is that in order for us to get ahead of the HIV epidemic, we really need to prioritize funding for the opioid crisis. As I mentioned previously, I am from community. And so during my time working in Boston, Massachusetts at the Multicultural AIDS Coalition, I got to see firsthand the effects of the opioid crisis, especially as it was exacerbated during the COVID-19 pandemic. What we saw on Massachusetts Avenue, what's locally called methadone mile, were people who were homeless, who were using substances, literally unable to access housing, unable to access treatment and services because of the closure for medical systems during the pandemic, people unable to access testing and other services. And so, you know, if we want to end the HIV epidemic, we really need to prioritize treatment for opioid and access to these services. Next slide, please. For the CDC HIV/AIDS, viral hepatitis, STI, and TB prevention, the budget includes $1.471 billion, which is an increase of about $126 million from fiscal year 22. I think what's important to note is, I mean, anybody who's done this type of work in HIV prevention, we know that HIV and STIs go hand in hand. Having an STI greatly increases your chances of contracting HIV. If we want to, again, get ahead of HIV, we need to ensure that we're also providing not only testing, but treatment services for STIs. And so it's important to remember that even prior to the COVID-19 pandemic, we were seeing a steady rise in STI cases throughout the country. During the pandemic, we weren't able to provide as much testing as we were prior to. And then it's important to note that, you know, people were still having sex during the pandemic, not only just the individuals in the community in general, but people who relied on sex work to survive. And so we need robust funding for STI testing in order for us to be able to not only catch up to what was happening prior to the pandemic, but also to get ahead of what, you know, the deficit in testing and treatment services that occurred during the pandemic. Next slide, please. And so this is something that's new in this budget proposal. There is a new mandatory PrEP program that is calling for $237 million to be invested just for the fiscal year 2023. That really comes down from $9.8 billion over 10 years for guaranteed access to PrEP at no cost for all uninsured and underinsured individuals. The funding also ensures that essential wraparound services are provided throughout the states through tribal entities and localities to establish a network of community providers to reach underserved areas and populations. And so when I think about this, I think about, you know, the access to PrEP that we had in large metropolitan areas. Here in Chicago and in Boston, we've had pretty strong access to PrEP. There's definitely still deficits, especially for people who are underinsured and uninsured. But we are facing deficits in these metropolitan areas. I can't even imagine what the deficit is like in rural communities. We know that HIV is still, you know, spreading in those communities, but they don't have the same level of access to PrEP services that we do in large metropolitan areas. So if we're having issues being able to connect people to these services, I can only imagine what's happening in rural communities. Next slide, please. I wanted to include just a visual representation of the numbers, right? So we talk about all of this funding, millions of dollars. What does it really look like? So when we look at the Ryan-wide HIV/AIDS program, the community was requesting an increase, and this is increase asked in millions. We're asking for an increase of $447 million over fiscal year 22, and the president requested $160 million. When we look at HAPWA, the community was requesting an increase of $150 million. The president requested an increase of only $5 million. When we look at the opioid-related infectious disease programs, community was requesting $132 million, and the president requested $1.5 million. As you can see, I mean, this is just a visual representation. The funding requests are totally inadequate in the budget. If we want to be serious about ending the HIV and AIDS epidemic by year 2030, we need to put our money where our mouth is. And by we, I mean Congress needs to do their job and actually fund these programs at adequate levels. Next slide, please. So the HIV community's fiscal year 2023 budget asks, we're demanding that Congress fund the following programs at these levels. For the Ryan White program, we're requesting $2.942 billion. For HAPWA, we're requesting $600 million funding. Minority AIDS initiatives, $610 million across all programs. Opioid-related infectious disease programs within CDC, $150 million. Next slide, please. So what do these numbers mean to the community? I think it's very easy for us to get lost in these huge sums of money, especially if you're not a policy wonk, somebody who's constantly, reviewing this information. It's very hard to kind of translate that to our everyday lives, right? For any of you who are actually doing the work in the community, I think your stories are totally invaluable as you're talking to these legislators and trying to help them understand why they need to do their job and fund these programs at adequate levels. When I think about my work in the community, I think about, clients that we served who were living with HIV, who had not been using substances for decades, who relapsed due to the pandemic. I think about clients who we're serving who are living with HIV, who have been on waiting lists for housing for months, if not years, as was previously mentioned. I know that even in these communities, in large metropolitan areas where we have more resources, we're having all of these issues being able to link people to these services. Again, I can't even imagine what it looks like in rural communities. And so I think it's important for you all to bring your perspective, to bring your experiences, your stories to these legislators to help them understand. One thing that I believe I missed was PrEP. There's the PrEP program. So even as we're doing, during the pandemic, we were trying to provide testing to the community. We saw people drop out of PrEP care just because, we weren't providing the same level of testing. Physicians weren't able to bring clients in for testing for their labs to be able to prescribe the PrEP. And so we saw a lot of people actually fall out of use of PrEP. The issue with that is that we've had such a hard time being able to re-engage them in care that we need this extra funding, this additional funding to be able to not only re-engage them, but to be able to provide more access to the community. Something that will be interesting to look at is how this funding will be able to increase access to things like the long-acting injectable PrEP, which we know will benefit people who are using substances. If for any of you who are not too familiar, so PrEP is a pill that you have to take every day to provide protection against HIV infection. Now there is an option for long-acting injectable PrEP where people can take an injection once every 2 months to prevent HIV. And so it'll be, again, interesting to see how this funding goes to help to bringing access to the community to this new resource. And that is it for me. Thank you.
Thank you, Omar. So our next speaker is Carl Baloney from AIDS United. Carl, unmute yourself. Yeah.
Thank you. I'm unmuted. I'm not being allowed to start my video, so I'm hoping maybe tech can start my video. There we go. Okay. All right. Well, thank you, Dr. McCray, and thank you, Omar. Really appreciate your overview. I'm going to talk about a couple of really key topics for AIDSWatch. And one is actually PrEP. And I know we just heard from Omar on PrEP, but it bears repeating. I think we all know that PrEP has been an amazing biomedical intervention that's been available for a little over a decade, but we know it still hasn't been reaching the communities that need it most. Omar's experience across 2 cities just really highlight for me the need for a national PrEP program. It's something that we as advocates have known about for a really long time. We know that it's a really essential tool to ending the epidemic in the US. But it's really important to point out that, the president has been grappling with his response to COVID-19 along with leaders in his administration. And that's where the majority of new resources and engagement has been. But as you know, he released his recent budget just earlier last month, and it includes, as Omar mentioned, $237 million for a new national PrEP program in FY23 alone, and an additional almost $1 billion a year over the next 10 years for PrEP. That's amazing. The president's budget is his stake in the ground to demonstrate his priorities for the country, and having $1 billion a year for a new PrEP program is monumental. I think the task that is next for this community, and we know why we gather for AIDSWatch, it's not only community, it is not only skills building and networking, but it's really to come together and create an assessment of how we can end the epidemic together. So it's incumbent upon us to work with the administration, to work with the Congress to ensure that we see this program come to fruition, that we see that the Congress actually fund this 237 million in year one, this additional billion per year, year over year for the next 9 to 10 years. And we can do that, as HIV advocates. It's really amazing that this timing is aligned with AIDSWatch, that we can go to the Hill and we can say in our meetings tomorrow, fund this program, we can end the epidemic together. This is what we are experiencing in our communities across the country. And you can speak firsthand about your knowledge as it relates to HIV prevention, care, and treatment. And as we've been hearing so much about the critical role so far over the course of the past few days and over the course of this panel. Details of the proposed program are still murky. So again, really, we can weigh in with federal agencies as advocates to tell them what is needed to actually implement a national program. We just got to get the money. So we're going to do that tomorrow, and I'm really excited about it. Another program that I want to talk about is the Minority AIDS Initiative. We want to make sure that Congress hears from us about MAI. This program has existed in some form or fashion since 1999, with members of the Congressional Black Caucus and the Congressional Hispanic Caucus, the White House, and the CDC were presented with troubling data showing the burden of the HIV epidemic on communities of color. Unlike other federal funding, MAI funding supports work by agencies across the federal government, breaking down silos between programs, and MAI can bring together federal agencies and countless grantees to address specific problems in care delivery. Whether that's providing HIV care training for clinicians, developing materials for people living with HIV to get involved in community planning bodies, or incorporating new services such as substance use treatment into existing HIV programs, and more. We need Congress to fund the Minority AIDS Initiative at the level of $602 million this year to support this vital work. Another note that I want to raise is beyond funding for MAI at an adequate level, Congress should implement the requirement that MAI funding support organizations and work led by people of color, not only those serving communities of color. Meaningful involvement of community members most impacted by HIV is one of the only ways we will be able to successfully end the epidemic. This is the remainder of my update. I'm looking forward to questions and comments. Camila, I want to pass it on to Nana.
Great. Thank you so much, Carl. Thank you, Dr. McCray, and thank you to all my fellow panelists. It is an honor to be here today. So I'm going to talk a little bit about the Ending the HIV Epidemic Initiative, also called EHE for short. EHE was announced under the previous administration, and it represents the most significant and cohesive federal investment to date in the efforts to end and address the domestic epidemic. EHE supports funding for HIV prevention, surveillance, care, primarily, and it is one critical component of the National HIV/AIDS Strategy in terms of actualizing the vision of the National HIV/AIDS Strategy. And for folks who aren't familiar with the National HIV/AIDS Strategy or the NHAS, that is kind of the overarching framework that guides the domestic response to the HIV epidemic. EHE is one major component of the NHAS, although the NHAS is more kind of like holistic than the EHE. And there are some opportunities for the Ending the HIV Epidemic Initiative to better embody the holistic nature of the National HIV/AIDS Strategy, which was released in December 2021 under the incredible leadership of Director Harold Phillips at the Office of National AIDS Policy. But to make the vision of the Ending the HIV Epidemic Plan a success, our federal response must rest on pillars of human rights, racial, gender, and geographic equity. It must, as other panelists have said, center leadership from those who are most directly impacted. It must promote safety and dignity for all communities that are at risk from harm and which are disproportionately impacted by HIV. And it also must honor true and holistic wellness. And so what does this look like in practice? Well, some considerations for Congress as you're thinking through conversations with your members tomorrow in your visits, are that Congress should really fund in ways that allow us to move beyond a purely biomedical model by integrating structural drivers and human rights approaches. So our vision of addressing the HIV epidemic and of the effectiveness of the EHE plan cannot be, it does not happen in a vacuum, right? We heard from earlier panels today on the importance of what is going on at the state level. We have anti-trans legislation. We have, we have attacks on repro rights happening. While we were here today in our sessions, actually, Oklahoma pretty much dismantled abortion. And it really makes no sense to think about HIV work completely outside of the context of uplifting human rights and dignity for our communities. So EHE jurisdictions should be incentivized also to actively work on creating an affirming human rights environment for communities that are most directly impacted by HIV. Imagine sending millions of dollars to a jurisdiction to work on addressing their HIV epidemic while we still have laws that criminalize people living with HIV in that jurisdiction, and not having any incentive for those jurisdictions to work on addressing those laws, for example. That is something that we can clearly build in better to our ending the HIV epidemic plans. Jurisdictions should be incentivized to actively work on creating an affirming human rights environment for those communities that are most impacted by HIV, including decriminalizing HIV, sex work, promoting harm reduction practices, and ending practices that surveil and police our communities. We also heard earlier about the importance of protecting and ensuring quality of life for people living with HIV as part of the response. So this is in the packets that you all will be referencing, but one of the things that the US People Living with HIV Caucus and networks have called for is acknowledging a minimum standard of care and a minimum standard of quality of life for people living with HIV, and promulgating regulations that would require providers to adhere to those minimum standards and also monitor and report how these standards are being upheld. What does this mean? This means success for us must be measured as more than our viral loads. Success for people living with HIV. There are 1.2 million of us living with HIV in the US today, and we're more than just our viral loads. We deserve not just to be virally suppressed, but as Kathy has said, to be stably housed, to have enough food to eat, to have nutritious food, to be safe, to be supported. As Carl Baker said, to have support and not be isolated, as a lot of people who are aging with HIV are facing, to not make choices between our healthcare and other basic needs. So healthcare, housing, food, these are all human rights. And quality of life in this holistic way for people living with HIV is something that the Ending the HIV Epidemic program can be more accountable for as well. We also, in order to really achieve that, we need true cross-government collaboration. So not every agency which can be included and funded were included in the plan, like the Department of Housing and Urban Development, or HUD, for example, like the Substance Abuse and Mental Health Services Administration, SAMHSA. Those agencies are currently not mentioned in the EHE plan, and should be included and should be resourced to be part of a key part and a core part of ending the HIV epidemic federally. Also, for the agencies that are currently in the plan, we need them to be robustly funded to implement this plan. And so the ask that we're making is for a total of $850 million, which is an increase of $377 million, which is in the president's budget. And so specifically, this is an increase to $310 million for DHAP, the Division of HIV Prevention within CDC, a total amount of $172.3 million for community health centers within HRSA, which is an increase of $50 million. A total amount of $52 million for Indian Health Services, which is an increase of $47 million. And a total amount of $290 million for the Ryan White program, which is an increase of $165 million. And so to be clear, this is specifically supplemental funding for the Ending the HIV Epidemic program. This is in addition to the other asks that we are making for these federal agencies that my colleagues have already mentioned. A couple of last things I would say are that we must have, and I think some of the panelists have spoken well to this throughout the last couple of days. By the way, what an amazing lineup of speakers we've had this year. We must have meaningful involvement of people living with HIV throughout the federal response and of communities that are most directly impacted and disproportionately impacted by the epidemic throughout the federal and local responses. And that means that it is not just about how much we fund, but as Carl Bologna stated, it is also about who we fund and who we resource to actually deliver these services. Unfortunately, over the last 10 to 15 years, we have seen a decimation of a lot of community-based organizations that are led by BIPOC communities and that are provide culturally relevant services that know what their communities need. So, Black-led organizations, Latinx-led organizations, API-led organizations, Indigenous people-led organizations that have really kind of gone off the map. And so we must have resources allocated in ways that resource leadership by those organizations, organizations that are led by those communities, not only organizations that serve those communities. So we must always center, uplift, and respond to those communities that are disproportionately impacted throughout our response. And we can do that by ensuring that the EHE response is really robustly resourced and funded and is truly holistic for our communities. Thank you so much.
Thank you, panel members. These were all really excellent presentations. And so I have some overarching questions that I wanted to ask all the panel members, but I'm quickly looking at the Q&As, and I see there's a few there. But I wanted to just start by having you guys talk a little bit more about this issue of level funding and the impact that it can probably have. So we know that funding increases have been requested for each of the programs that we discussed in this session, but level of flat funding, that is funding that is at the FY 2022 level, is possible as what happened in 2021. So can you describe the impact that level or flat funding in FY 2023 will have on your programs? And I know, and we can start with you, Kathy, because you sort of alluded to that in your presentation, and then we can go to others who want to respond.
Well, I think everyone knows that COVID has really impacted our environment. And I had to laugh this year because, every year HUD comes out with fair market rent guidelines for us, and we have to stay within those guidelines. Do you know the fair market rent in Birmingham went down according to HUD? And we are struggling to find landlords and people that we've used in the past because they're finding themselves in a market where they can charge more. And that's only hurting our folks. So when we get a 1% increase in HOPWA, I mean, that goes right down to the front line where people are trying to get housed and stay healthy. And so even in a place like Alabama, we have long waiting lists for the piece of the housing opportunities for persons with AIDS that I think is the most helpful to people. And that's the long-term tenant-based rental assistance vouchers, because that's consistent every month, and it helps people not pay more than 30% of their gross income on their rent. But that's also the program that has the longest waiting list for HOPWA. So, it's kind of a catch-22. But what frustrates me is that we need for our legislators to understand the integral piece that food and housing and poverty plays when it comes to HIV. And one thing I did want to mention, I'm grateful that the Biden administration seems to care. I truly am. I'm grateful for the parts of the portfolio that got more money, but they clearly don't seem to understand the impact of lack of housing for people living with HIV. So I'll leave it there for now.
Okay. Any other panel members have any comments about this issue?
I would just,
Carl. Oh, sorry.
oh, go ahead. Go ahead, please.
No, go on, Nana, and then Nana, and we'll go to Carl.
Yeah, I would just really, uplift, I think, what Kathy is saying. What we know is that although it might take a while for the data to catch up, we know that our communities are actually doing much worse than they were a few years ago. And unfortunately, we don't have that data yet, but we know every day that we're hearing from members, from people living with HIV, who are like losing their housing, who don't have enough food to eat, who are taking care of multiple family members with increased economic pressures. The situation for our community is unfortunately really dire. And so the idea of flat or level funding, that is not actually flat or level funding, because we also have inflation happening.
That's right.
We also have competing pressures. We have gentrification happening in a lot of places where folks are living. And so I think we need to be really clear in our messaging that flat funding is not flat funding. It is a decline in funding and resources when the disparities and inequities are only growing right now.
Carl Ballany, do you want to add anything?
Sure. I mean, I think Nana really zeroed in there, but just I think to make it really practical, we all know, we know the cost of goods, we know how it's hitting our pocketbooks, and things cost more. It's just more expensive to live and exist in 2022 than it was most certainly even last year or just a few years ago. I think community-based organizations that provide care and support to the HIV community are a lot like families, right? They stretch scarce dollars to meet the needs of their communities, just like we do to meet the needs of our families. And if things are level, we're not going to be able to meet those needs. And that's critical. If we really want to take seriously ending the epidemic, we have to increase funding over current levels.
Okay, if there's no other comments on what I want to do now is move.
I'll make a comment real quick, Eugene.
Yes, please. Yes.
Sorry about that. I think it's also important to note, so Congress has a mechanism called continuing resolutions, by which if they're not able to pass a budget by the time that they're supposed to, they can continue funding the government to avoid a shutdown at base levels of what the previous budget was approved under. If Congress really has one simple job, which is to fund the government, they have, or at least the House has the power of the purse. By going through the appropriation process, by funding these programs, they are basically setting the national priorities, right, for how we move as a country. If they don't do their basic role, which is to fund the government and at adequate levels, especially these programs, then what really are they doing, right? And so it's important for them to not only to continue to push the ball to the end through continuing resolutions, but to actually take robust action and fund these programs when they're supposed to. That way, our programs can actually plan for the future and to really understand how they're going to move forward into the future.
No, thanks for that comment, Omar. And I was going to ask Carl, could he say more about continuing resolutions, because I think it's important for the audience to understand what that really mean, and maybe give a concrete example like last year, FY 2021 appropriations, and what that process looked like with the ongoing continuing resolutions, and the impact that could have.
Yeah, I'm happy to. Basically, there's a normal cycle of things, the way things are supposed to happen. Then there's what actually happens, right? So the president releases his budget. It is the marker for his core priorities, his or her core priorities. The Congress follows suit, and they set top line allocations, the top amounts of money that can be spent across the discretionary spending, the discretionary and mandatory spending. So the 12 appropriations bills under discretionary spending, levels are set, and then Congress goes to work to actually put basically funding under each account. And more often than not, over the past decade, that process has broken down. They can't find agreement. And instead of making proactive steps to initiate funding that's needed across the sectors, they kind of throw up their hands and they say, okay, we're just going to continue funding through the rest of the year, the month, whatever the cycle is, to make sure that things don't shut down. And I think many of us remember, I think 3 or 4 times over the past 8 years, the federal government has shut down, parks closed, folks got furloughed and couldn't go to work. services were halted. We know how much that impacts us, and so that's the impact of a CR at the basic level. But then again, we talked about it not also raising funding to meet current needs as well.
Thank you for that clarification. I want to go and take one of the questions from the Q&As that were sent in, and there was just a couple of questions directed to you, Kathy. And I wanted to just sort of briefly, I know you sort of respond to them in writing, but I think it's important for the rest of the audience to hear what you're saying. But this was a question from, I believe, Robin Webb, and she's basically saying, or this person is basically saying, if we advocate for $600 million for housing, how does that play out procedurally? How does the Congress members then take action? Do they speak up and push this before the Budget Committee? Do we have congressional champions that we can support who are already pushing for the $600,000, the $600 million? Sorry.
And that's a great question, Robin. So for the HOPWA allocation, I would encourage folks, don't get too depressed over the president's budget, because the House and the Senate each have to come out with their budget, right? And oftentimes, I can remember many years when people say, oh, the president's budget is trash. We're not going by the president's budget. So, what's even more important is what the Senate and the House come out with. Now, once they put their numbers out, then generally what happens, as Carl was saying, in a normal world, is they say the Senate said 450 million and the House said 600 million. Then they would get together and compromise on that. So it's really very, very important for us to get higher numbers from the House and the Senate. And that's your job, as you're out there talking with our elected officials, is to make them understand how important that is. So, again, don't get too discouraged by the president's budget, because hopefully it won't end up at that level. But we have a lot of champions. It's usually the same suspects, people like Dick Durbin and Jack Reed and Barbara Lee and Maxine Waters. It's generally Democrats, as you can imagine, that are looking to help shore up the programs for low-income people. But don't let that stand in your way either. I come from a state where I have one Democratic representative and 6 Republicans. And I've had to learn over the years, you just keep going and going and going like the little Energizer bunny, and don't give up, and sometimes your message gets through when you least expect it. So I just would encourage you to try to connect with your Congress people and help them to understand how important this is.
Okay, thanks, Kathy. There's another question, and I'm not sure it's directed to anyone specifically, but Carl, you may want to start, and then others can add in. But this question was also, how do we combat legislators arguing that money spent on Ukraine relief and military assistance leaves nothing left for aid services funding? I think that's an important question, and several of you may want to comment on that. Does anyone want to start?
It's their job to fund both of those things, right?
Yeah.
Don't forget these people work for you, and they need to support their constituency as well as the people in Ukraine. It should never let anybody force you into an either or. It can be both. They can find the money when they need to.
Yeah. I think another thing that I'm sorry, I hope, Kathy, you were done. I'm going to just.
No, I'm done.
Thank you. I think another thing that we have to remember and remind them of is the importance of prevention and the effectiveness of prevention, right? So, and prevention doesn't just mean for HIV negative people. It is making sure that people who are living with HIV are well, or healthy, or housed, or fed, or safe. When folks are in a good place, it costs less money to take care of them. When folks are adequately housed, they have lesser medical bills, and so on and so forth. So just like it's important for us to invest in the Ukraine and make sure that the world is safer, it's important for us to invest in our own communities and make sure that they're healthier.
Carl, can I piggyback on that? I found it effective speaking to legislators to actually show them the difference. It only costs $5 for a PrEP. I'm just making up a number. $5 to prescribe PrEP for a month to the cost for Medi-Cal. Conversely, if someone gets admitted to the hospital with advanced HIV, we're talking $500,000. So the savings is better to use the money in prevention than it is to wait till someone's chronically ill to treat, because the government is going to pay either way. So you can pay less today or pay more 5 years from now.
So thank you. Thanks, everyone. Carl, I have a question for you. And you began or alluded to this in your presentation, Carl Baker, that is, I'm sorry. And this specifically about people 50 years and older, like us, who are living with HIV. Could you talk a little bit more about what improvement you think are needed to the Ryan White program to ensure that there's more holistic care being provided for folks like us who are living with HIV?
So one approach we took in California, we passed legislation last year that called HIV and aging one of the greatest social needs of our generation. So we actually had the legislature take HIV and aging and add that to their docket for help of senior citizens and aging. So because our numbers are so large here, that it really is a powerful mechanism when we go to Sacramento and say, here's this large group of people that are over 55 and are facing chronic comorbidities at an earlier onset of age, and they need care. And one thing that we found a huge gap in were behavioral health services for HIV and aging individuals. Again, that isolation, those people even who have insurance or a retirement fund end up living alone. There's no one to take care of them. How do you get to the doctor if you can't drive anymore? So there are a lot of needs that are not being addressed just because people think, oh, well, you're taking a pill every day, so you should be able to take care of yourself. That's not the situation.
Mm-hmm. Okay, well, thank you. But I wanted to just check in. We are now at 7:04, and I think the session was scheduled to run until 7 o'clock. I certainly have more questions, but I think I'm supposed to end now. But before we end, I again want to thank all the panelists for these excellent presentations and for the Q's and A's. And I guess before we sign off, I wanted to just know if anybody had any burning comments that they wanted to share directly related to their worker concerns, things that you think our advocates should know as they go on the Hill and advocate for resources. Okay.
I want to thank you all so much for doing these visits tomorrow. They're really incredibly important. And as I know we've said throughout AIDSWatch, the importance doesn't end tomorrow. So going and visiting your representatives, your members in their home districts as well is also really helpful for them to, to know that you're there, showing up, watching them, keeping an eye on everything. There is so much at stake right now, and your participation is just incredibly vital. So thank you for doing this.
So thank you, Nana. Thank you, Nana, for those comments. For those of you, we will be looking at the Q's and Q&As just in case we missed some. And if we did miss any, we'll try to make sure we respond in writing. But anyway, I want to thank all of you for joining the session. And again, I want to really thank our excellent presenters, panelists, and thank you all for all of the really good responses that you gave to the questions and so forth that were raised. And hope the rest of you, all of you, enjoy the rest of your evening. Thank you.
Thank you.
If I may, Dr. McRae and everyone, again, thank you. Thanks for attending AIDSWatch. This was a really wonderful event. Also, just want to flag again for those of us doing congressional meetings, please go and check your Soapbox mobile tool. If you have any cancellations, please let the team at Soapbox know. And we're really looking forward to continue our advocacy in partnership with all of you.
Bye, everyone.
Bye-bye.
Nora, do I need to stay on?
No, sir, I think we're all set. Thank you.
Okay, all right, thank you. And thanks for the opportunity.
What a powerful session.
Okay, yes, it was.
It
Thank
was
you.
our pleasure. Thank you.
All right, bye-bye.